is if the physician spends the majority of their practice prescribing or dispensing scheduled drugs. It's kind of a blurry line, but from my perspective, there are legitimate physicians out there that treat patients with chronic pain with scheduled drug medications. That doesn't make them participants in the pill mills. To me, what the pill mills are about is having people that are coming specifically and entirely for the medication. They come in, they bring some MRIs, they bring some lab results or some tests or reports from other physicians. The physicians there take a brief look at them and prescribe them a long list of medications, which most times are filled right in the dispensary or pharmacy within the same building. Big difference right there is the only focus really for those patients is to get their medications and move on until the next time that they come. Those that have been in the news are very easily recognized by the long lines of patients there carrying large wads of $100 bills.
Right, and many of them are from out of state. We see Kentucky, we see Tennessee, we see Ohio. Just the other day, we're working on a story that involves a pharmacy in North Dade. And my photographer and I were sitting in the parking lot watching the activity there, and there were 25 out-of-state cars. 25 at one pharmacy. I don't think that they were there for legitimate pain issues. Now, Dr. Sandhouse, another question here I would think would be the legislation that there has been some passed, we have some laws going into effect, we have some regulations going into effect, but there are other bills pending in the legislature, some that would do some good maybe and some that wouldn't. What are your thoughts there?
Well, the legislation that I've been involved in is with regards to maintaining standards for the physicians who practice in pain medicine. The Florida legislature passed statutes that require the registration of pain clinics who either advertise or are involved primarily in the prescribing and dispensing of medications. What then happened was, through those statutes, it allowed the boards of medicine and osteopathic medicine to look at creating an administrative code that set up specific standards for the operation of those clinics, and more specifically, the requirements of education and practice for the physicians within them. One of the nicest things that they put into these administrative codes was the requirement that physicians that have not been specifically trained in pain medicine, either through residency programs or board certification, either in pain medicine as a subspecialty or through the American Board of Pain Medicine, physicians who are not primarily pain specialists by training can still practice. But what will be required starting in January of 2012 will be that these physicians will have to undergo anywhere from 80 to 120 hours of continuing education put on by accredited medical schools in the state of Florida, which Nova Southeastern University is one of the proud partners. The Board of Medicine actually said that the physicians who want to practice in this field will have to take this course every 2 years upon renewal of their licensure. The Board of Osteopathic Medicine made it every 6 years, with 20 hours of continuing education in between. The course's focus is not just medications, though, because, again, that's part of the problem with pill mills is that's all they focus on. The course focuses on the true multidisciplinary aspect of pain management, including medications, medical intervention, both from the standpoint of injections and other procedures, as well as things, for example, what I do here, which is osteopathic manipulative treatment. Non-invasive, non-interventional, but nonetheless very helpful for patient care and to work as a team. It requires that the physicians learn about the documentation issues, psychosocial issues of pain and addiction, what the legal aspects are, and what happens if you violate those legal aspects. So for the physicians that want to continue to practice in the pill mills, they'll still have to take these courses, and then they can't turn around and say, I didn't know what the laws were, because part of this course will need to tell them exactly what can happen to them if they go outside of the standard of care.
Dr. Bucara, what are you finding in terms of the patients that are addicted to pain medicine? Are you finding, are they younger, are they older, or are they still all across the board?
Currently, they're still all across the board. However, I do a lot of treatment here in the Fort Lauderdale area. We see about 120 patients a week at my private practice, and we also own a sober house. And what we're seeing a lot of are a lot of younger people, going to these clinics and getting the pain medications. And we're also starting to see a rise not only in the pain medication, but if they can't get that, they're going over to heroin. So,
Good God.
so I'm seeing an increase of heroin also, because if they can't get the pain med, then they go after that. So we're still seeing it all across the board, but one of the things I want to make clear is that as a psychologist, one of the things we have to do is do a good biopsychosocial history. Because by doing that, you look at several different things. Look at their history of other addictions, because people are known to switch addictions. You also look at the family history of addictions.